Welcome to The Explainer. Today, we're going to tackle one of the most common and honestly, one of the most misunderstood conditions out there, Polycystic Ovary Syndrome. You probably know it as PCOS. So let's just jump right in with the biggest question, the thing that causes so much confusion. What if the name itself is, well, just wrong? Because it really is misleading, so much so that experts have talked about changing it for years. Yeah, you heard that right. The name is pretty much a myth. The word polycystic brings a certain image to mind, and it's probably not what's actually going on. So let's bust this myth right now. Okay, so when you hear the word cysts, you're probably thinking of these large, painful growths, right? Something dangerous that might even need surgery. But with PCOS, that's not it at all. The real word we should be using here is follicles. A true ovarian cyst is a big, fluid-filled sac. What we actually see in PCOS is totally different. They're tiny, undeveloped egg follicles, usually only about 2 to 9 millimeters, and they build up inside the ovary because ovulation has stopped working correctly. This is what creates that classic string of pearls look on an ultrasound. The most important thing to get here is that these are not dangerous cysts. So if it's not really about cysts, then how in the world do doctors diagnose it? Well, it actually comes down to a really clear and simple rule. The official gold standard for diagnosis is something called the Rotterdam Criteria. It sounds complicated, but really, it just boils down to this. To get a PCOS diagnosis, you have to check at least 2 of 3 specific boxes. So box number 1 is all about your period. The technical term is oligoanovulation, which is just a fancy way of saying your periods are really infrequent or you're not ovulating regularly. This could mean you're getting fewer than 9 periods a year, your cycles are way spread out, like more than 35 days apart, or you've just stopped getting a period altogether for 3 months or more. The second box doctors look for is signs of high androgens. Androgens are hormones like testosterone. Sometimes this is really obvious physically. You might see things like hirsutism, which is excess hair on the face or chest, or you might have really persistent acne or even notice hair thinning on your scalp. Or a simple blood test can just show that your hormone levels are elevated. And finally, the third box is the one that gave this condition its confusing name. It's the appearance of those polycystic ovaries on an ultrasound. Specifically, a doctor would be looking for 20 or more of those little follicles on an ovary, or just seeing that the overall size of the ovary has increased. Now, this part is absolutely crucial, so listen up. You do not need an ultrasound to be diagnosed with PCOS. Seriously. If you have irregular periods and you have signs of high androgens, that's enough for a diagnosis, as long as other things have been ruled out. That image is not a mandatory piece of the puzzle. So we know what it looks like, but what's actually causing all of this? This is where we have to look deeper, because even though PCOS messes with the reproductive system, its roots are very often metabolic. For most women with PCOS, there's a hidden engine driving this whole thing, and that engine is insulin resistance. It's a condition where your body's cells just don't respond to the hormone insulin the way they should. And this is incredibly common. We're talking up to 70% of women with PCOS who are obese have it. But here's the kicker. It's not just about weight. It also shows up in about 30% of lean women with PCOS, which surprises a lot of people. So how does this work? It's like a chain reaction. Your body senses the insulin isn't working, so it just pumps out more and more of it to try and compensate. Well, all that extra insulin in your system goes straight to the ovaries and tells them to produce way too much testosterone. And it's that excess testosterone that messes up your whole cycle and stops ovulation in its tracks. Okay, but here's where it gets a little tricky. The symptoms of PCOS, things like irregular periods or extra hair growth, they aren't unique. So a really critical step is making absolutely sure it isn't something else pretending to be PCOS. In medicine, we have a term for this. It's called a diagnosis of exclusion. And all that means is that you can only be sure it's PCOS after you've looked for and ruled out all the other conditions that can look just like it. You can kind of think of it like a filter. You put all the symptoms in at the top, but before a PCOS diagnosis can come out the bottom, a doctor has to filter out and catch other possible causes, like problems with the thyroid or adrenal glands. And this is usually done with a few pretty standard blood tests. A TSH test will check your thyroid function, a prolactin test checks for high levels of that hormone, and another one, called a 17-OHP, is super important for ruling out a genetic condition called NCAH, which can be an almost perfect mimic of PCOS. Okay, that was a lot of information, I know. So let's just boil it all down. What are the absolute key things you need to walk away with today? Let's go from confusion to clarity. First, remember, it's not about cysts. It's about undeveloped follicles because ovulation stalled. Second, the diagnosis is all about that 2 out of 3 rule, and you don't always need that ultrasound. Third, for so many people, this is a metabolic issue at its core, often driven by insulin resistance. And last but not least, a doctor has to rule out the mimics before confirming a diagnosis. This really says it all, doesn't it? The way you feel and the symptoms you have are powerful. You can have irregular periods and acne, and that could be PCOS, even if an ultrasound comes back looking totally normal. What you experience is often way more telling than what an image can show. Look, understanding how this all works, the name myth, the 2 out of 3 rule, the metabolic engine, and the mimics, it gives you the power to have a much better, much more productive conversation with your doctor. So the next time you think about PCOS, maybe the question isn't just what is it, but why is it happening? Because the answer for so many isn't just in the ovaries. It's connected to your whole body's metabolic health.